And thank you again for what you've done, what you do today, and what we think you will do for us in the future, and our mutual goal to assure great access to wonderful care we provide at community health centers. I love working in a community health center, and you can hear the passion in Margaret's voice and everybody else's, and without you, we couldn't do it, and we thank you. The other piece I want to say, just as a personal side, is I'm not a spring chicken anymore, but every time I come to D.C., I have to say that I just love coming here. I'm in awe of what you probably take for granted every day, which is being in this building, doing all the things that you do. It just makes me proud to be an American, so thank you. So let me tell you a little bit about us. We are Piedmont Health Services. We are also an FQHC. We serve about 40,000 people with nearly all of our patients at 200% of the federal poverty level or below. We proudly have primary medical care. We have over 40 medical providers, and we're thrilled that we have the people we do. But one small example, and I think everybody can do the same thing, let's talk about our prenatal care. So we provide prenatal care to just about 1,200 women every year. And what that translates in a different way is every day, 3 babies, or every 8 hours, a healthy North Carolinian is born because her mom got, or his mom got care at our place. And we're proud of what our doctors do. But in addition to that, we also provide dental care and WIC services to about 6,000 women and children. The other piece we want to thank you for is our 340B drug pricing piece. We're fortunate to have on-site pharmacy services, and as a result of that, we can purchase drugs at approximately $4.20 a prescription and provide care, that pharmaceutical care, to our patients at Walmart pricing. So we can provide care at $4.10 a prescription, which is very different if they were trying to get that in the retail market. I also want to thank you also for the AURA funds that we received. I think Margaret expressed it well. We took that money and we've used it wisely. We also have electronic health records, and those are great things to have, except when the power goes down. So we used some of those funds to actually build generators so that we will never be without our records, no matter what the power situation. And we also used it to build one of our new facilities, and you're all welcome to our groundbreaking when we have that in June. We received hundreds of thousands of dollars under the IDS grant. Again, thank you very much for that. We know that that's not an easy thing for you all to do, and that allowed us to continue to fund parts of 18 positions in our facilities. And we're looking forward to continuing with those people in our programs. We're also all aware of the fact that expansion of services is what we're really ready to do. We're ready, willing, and able to do, and that's the part we're asking you to help us for in the future. But one of the programs that we're looking to do is with a schools system in Burlington, North Carolina. This school system has both rural and urban schools, and one of the schools that asked us to help them is a school that's one of the failing schools, if you will. And so this is a school that over 90% of the kids qualify for school lunch, assistance, and in addition to that, almost that same number of children, the same percentage of children, also aren't meeting end-of-grade tests. This is a pretty smart leadership group that they have at the school system there, and they asked us to come there because they think that health care and preventive nutritional services would actually help these kids function better. So we would love to have that opportunity to work with them. But at the core of what we do, and I really want to emphasize this, is we believe that as a health center, there are 4 main rights that people should have when it comes to health care. And we think these 4 rights are fundamental to all the things that the healthcare system should focus on. And those 4 rights are the right care, at the right time, in the right place, at the right cost. And for those examples are pretty straightforward. We think that the right care just means that you provide primary care in a primary care setting, not in an emergency room. We think you make sure that you do surgery in a surgical facility, but you don't do you don't do primary care kinds of things there, or make sure you do primary care where it's supposed to be. And time also is important, because if you have right access to care, we all know easily enough that if you provide care in a delayed fashion, it costs more in the long run. But the other part of it, too, is that if you provide too much care to begin with, you're also providing unnecessary costs and unnecessary treatment. And we believe, because we're obviously biased as health centers, but we believe that community health centers really understand that primary care setting like we do understands how to provide that care in the best way possible. So, those are the rights that we think. And finally, the right cost. We think that if we actually follow those first three, then there might be enough money for all of us to get the right care that we need to get to in this country. And I look forward to being able to talk to my colleagues at UNC Healthcare, knowing that they have a great hospital system there, but I don't want them taking care of primary care patients in the emergency room. I want them to come to my place instead. So, the final thing I wanted to point out is that we know that we as a community health center are part of the community. And we have several programs that we provide. I think all of us can talk about those things eloquently. We're all justifiably proud of all the things that we do. But some of the things that we do in our place is we have a program called Carolina HealthNet, which is our partnership with UNC Healthcare, which aims to reduce unnecessary ER use and coordinate the care of the uninsured for specialty care at their facility. We also have in our state of North Carolina something called our 646 waiver program through CMS, where we're basically coordinating the care of the dually eligible so that they actually have someone who can take care of them in their homes and they don't have to be sent to the emergency room for unnecessary care there, but we can actually take care of them on the forefront and not waste dollars. We have our senior care program, our PACE program, which we're justifiably proud of, making sure this is a nursing home alternative. It's a capitated program where seniors can stay at home instead of going into a nursing home. And one other example is, and Dr. Flinter mentioned it, is our small business chamber program. Again, we're members of the chamber program. We are a private corporation, providing private jobs. And we recognize that one of the growing groups in our neighborhood of people who couldn't afford access to insurance was middle-class Americans. And so we worked a program with our 4 chambers of commerce we work with, so that if an organization is a member of that chamber of commerce, any of their employees or their family members can come to us for $60 a visit and then access our pharmaceutical rates so that we can make sure that we take care of our neighbors when they need to be taken care of. So I thank you very much for the opportunity to be here. Again, you have no idea what a thrill it is to see all of you. I've seen many of you on TV. And again, I thank you again for the fight you will fight for us on the future. Thank you.
Thank you, Mr. Toomey. We're glad to see you. Dr. Cole.
Thank you. Good afternoon. I appreciate the opportunity to speak to you all this afternoon about the use of information technology as it applies to rural health care. As you said, I'm Dr. Russell Cole. I'm a simple family physician where the rubber meets the road in a town of about 7,500 people in northeast Oklahoma. While I am a member of the Air National Guard and a member of the Board of Directors of the American Academy of Family Physicians, I have to make my official disclaimer and say I'm only speaking for myself today and not as a representative of either. I practice classical family medicine from conception to grave. I deliver babies. I see patients in my private clinic. I admit them to a not-for-profit county-owned hospital, see them in the nursing homes, and when they need to be seen at home, I go see them there too. And while it sounds a little bit like I may be kind of a modern-day Marcus Welby, I grew up watching Star Trek. And on Star Trek, the thing that I have always remembered is for a ship the size of the USS Enterprise, there was only one doctor. But that doctor had tricorders, and that doctor had computer systems, and that doctor had a well-trained medical staff that made sure that the doctor could do what the doctor needed to do. The vital signs, lab tests, and medications were all in the ship's computer, allowing Dr. Crusher, which gives away that I watched Next Generation, or Dr. McCoy to actually care for their patients. That's the future that I've been working for in rural Oklahoma. During my time in Iraq, I was introduced to a fairly clunky and not very user-friendly electronic medical record and public health tracking system that was in use by the Air Force at the time. It was a very far cry from the more intuitive systems that we use today, but it was tremendously better than the paper system that I had trained on in medical school. When I returned and established my private practice, I decided that I would use EMRs from the very beginning. However, this was still the Wild West of the EMR days. Companies came and went on an almost daily basis, and there were no national standards about how data should be stored or transmitted. Jonathan Kolerick, a medical informatics nurse with the Oklahoma Foundation for Medical Quality, which has since been designated a regional extension center, became an invaluable ally as I worked through the implementation and the redesign of clinical processes to take advantages of the system's resources. At that time, though, there were no programs to assist a rural physician in attempting to implement a program such as this. The local bank agreed to loan me $20,000 towards a $60,000 system, but advised me that, well, this is probably more of a fad than a necessity. Fortunately, since I was going into a rural practice, I was eligible for $40,000 from the state for student loan assistance, and through persistent badgering was allowed to convince the state to let me use it not for student loans, but instead to put it into an electronic medical record. The day I opened the doors to my private practice, I was over $250,000 in debt for my student loans and electronic medical record system I had implemented. Over the intervening years, I have been able to cut that number in half. Student loans have been paid at the minimum, and the money that could have been used to pay them off has instead been fed back into the project to continue to improve the care that we provide to patients. In many ways, though, this isn't really unlike many new jobs and new businesses that start up. The main difference in medicine is you get to start off with an additional $130,000 to $180,000 in student loans, and the price for the services that you provide is fixed as opposed to what you believe might the market support. Through presentations to community groups where they allowed me to actually show them the software and its capabilities, I gradually began to change the culture of small-town Oklahoma away from their initial resistance. As one of my patients who's a UPS driver told me, he said, "I can find a package anywhere in the world with a tracking number. How come the hospital can't find my lab results?" One of my most immediate supporters of the system, though, was one of the most paranoid people you have ever met on earth. While others were concerned that people would now be able to hack into and see the electronic medical records, it was she who pointed out that unlike the paper records previously, now there was a log of who had done it, what they had looked at, and how long they had looked at it. For the next couple of years, she asked for this report every 3 months, and I graciously handed it to her, and she was tickled to death that no one had ever looked at her records. From this early success, we've been able to expand to include 4 additional clinics, 3 of which are rural health clinics, as well as the Cherokee Nation Indian clinics, for a total of 12 providers ranging from nurse practitioners, PAs, and family physicians across 4 counties in rural northeast Oklahoma. It's led to the transition of our hospital from a paper-based system to an electronic medical record system with computerized physician order entry. And while no transition is ever simple, I had to laugh to myself when after 18 months on the system, we had to do a system upgrade. And I got to hear the nurses and doctors alike in the nurses station complaining, how in the world can they ever expect us to do this on paper for 8 hours? Our next steps, though, in utilizing technology to improve the quality are underway and involve tying our rural system into the adjoining rural systems through a statewide health information exchange. Once this is completed, a patient in rural northeast Oklahoma can go 100 miles in any direction unless they cross a state line, and their medical records will follow them. Even more exciting to me at this time is a pilot project that ties in home health and hospice nursing care that's actually provided at the patient's home and at their bedside, tying back into the system, not causing a duplicate record, but for once allowing our patients to actually have a unified, comprehensive medical record. While we are in the middle stages of a success story, our story isn't over yet, and every day I struggle with the possibility of failure. Living in a poor county by national standards, we have large Medicare, Medicaid, and uninsured populations. This has allowed our hospital to be eligible for the Medicare and Medicaid meaningful use funds provided for in the HITECH Act. Electronic medical records improve the care that's provided to patients through reduced errors and decrease healthcare expenses for payers by reducing duplication and improving the outcomes. However, unfortunately, the current healthcare system in the United States is based largely upon a fee-for-service model that actually penalizes providers for providing high-quality, efficient care. We all understand that this is simply not a sustainable system. Otherwise, you as a group would not annually have to hear about SGR, and I would not annually have to figure out which of my patients are going to begin paying me in tomatoes because the insurance doesn't pay the rent this year. Payment model revisions, such as those that are seen with the patient-centered medical home, are the long-term fixes to these problems. But the funding currently available through meaningful use is a critical lifeline, allowing for the healthcare information technology to be implemented in rural America, Oklahoma in specific in my case. To rural health care, the high-tech provisions of the ARA are the Hill-Burton Act of our lifetime. This time, instead of establishing the physical infrastructure that 50 years ago built rural hospitals throughout underserved America, the money is instead being used to build the health infrastructure that we will use to take care of rural America for the next 50 years. Thank you.
Amen to that.
Right.
Ms. Harris?
Great witness.
Thank you, Chairwoman DeLauro, Chairman Miller, and distinguished members of the committee. As introduced, I am a medical billing and coding instructor at the University of Antelope Valley, which is located in Southern California. The university offers higher education to the local community through the delivery of quality education, through the delivery of quality career-specific certification, undergraduate, graduate, and continuing education programs. Our student population includes adults over 18, many of whom do not have a high school diploma. Many of our students are changing careers or have been laid off. Some of our students are homemakers re-entering the workforce, and others are simply people trying to improve their lives by taking a few college courses. In 2005, after experiencing a layoff myself, I became a student at the University of Antelope Valley, then called the Antelope Valley Medical College. I enrolled in the Emergency Medical Technician Program, or EMT program, for $1,200. After successfully completing the program and passing the national certification exam, I began the process of seeking employment as an EMT. During that process, I was offered a teaching position in the billing and coding department at the university, which I accepted because it was a better offer than the EMT positions were offering. The medical billing and coding program at the university offers certificates and associate degrees and is designed to prepare students for entry into occupations that require employees to have training and skills in a variety of medical billing procedures. In the classroom, students receive daily instruction in the theory and practice of healthcare reimbursement. The curriculum I teach include history of insurance billing, the history of healthcare, anatomy and physiology, and medical terminology. The classroom-based instruction is enhanced with internships, externship opportunities in medical offices and billing companies, which often lead to employment. Students are also offered lifetime job placement assistance and are encouraged to obtain professional certifications to further enhance their marketability. As an instructor, I have seen high demand for entry-level medical positions that work under the supervision of healthcare practitioners to provide routine care or administrative support. Not only have physicians become reliant on medical support staff, but their services are being requested by hospitals, clinics, nursing homes, medical supply businesses, home health agencies, insurance, and pharmaceutical companies. The new health reform law will provide coverage for an additional 32 million Americans by 2014, resulting in the need for more health care support workers. Health support occupations include certified nursing assistants, home health aides, patient transportation staff, food service workers, as well as the administrative workers who admit patients, coordinate units, and maintain records. Most of these positions require on-the-job training or little to no educational preparation. In fact, more than 40% of the healthcare support jobs of the future will require no post-secondary training at all. The jobs that do require post-secondary education call for an associate's degree or certification. Furthermore, these entry-level healthcare jobs are the initial rung of the direct career ladder to higher-paying acute care jobs that require additional skills and training. Medical billers are an important component of the healthcare workforce and are an asset to any doctor's office. With the increasing use of electronic medical records, employment for medical billers is expected to increase by 20%. My university is preparing students for the diagnostic coding conversion to ICD-10 mandated under the healthcare law. Our instruction has changed to meet the new medical billing guidelines by including instruction in the new code set and teaching our students how to introduce the new format to other medical billers and medical office managers. As Representative Bass stated, another example of the future healthcare worker is the medical assistant. And the medical assistant is one of the fastest growing healthcare occupations. Due to the expanding healthcare industry, the current demand for the medical assistant is great and is expected to grow further in the coming years. While an inexperienced medical assistant may first earn an annual $20,000 salary, fully qualified medical assistants may eventually earn more than $40,000 a year. In addition, well-trained medical assistants have very good prospects for promotion in the medical field, being able to qualify for various administrative occupations and become medical technology professionals. In conclusion, the reform law is a jobs stimulus for the healthcare industry, creating jobs that will provide support to healthcare practitioners and improve quality patient care. With Los Angeles County facing a 12.3% unemployment rate, nearly 3% higher than the national average, healthcare reform is a critical and timely jobs engine we need. I thank you very much for allowing me to testify.
Thank you, and thank you all for your thoughtful testimony. We'll move to questioning, and I'd like to ask our colleague, and Mr. Miller pointed out at the outset that Congressman Clyburn has really had a long-time interest in this area and has been very focused on bringing attention to it. I'm just going to ask my colleagues. I would like to ask Congressman Clyburn to say a few words and ask his question, but I want to say to my other colleagues, we've got this room until 4 o'clock. We have a lot of folks here, and which is great, all of the members who are here. Let's be crisp in our questions, and I know that our panel will be crisp in their answers. So, Mr. Clyburn.
Thank you very much, Mr. Lauro. I want to thank you and Chair Miller and Ms. Ross for carrying the bass of this, for allowing me to be a part of this. And I apologize for my raspy voice here today, but I just came up from South Carolina, and I've seen pollen like I've never seen it before. And I think all of it is lodged in my sinus somewhere. Let me just say a couple of things, if I may. I first became acquainted with community health centers after taking former Senator Ernest Hollings on a tour of Charleston's east side, Charleston, South Carolina's east side, back in 1966. We looked at that community where I taught high school. And we followed that tour with a tour that he took of Beaufort County, South Carolina, with a Dr. Gatch. And he sat down after that and wrote a book called The Case Against Hunger. Out of that book and those two tours came the Franklin C. Fetter Community Health Center on Charleston's east side and the Beaufort Jasper Community Health Center in Beaufort Jasper counties. I had the great fortune a few years ago to sit next to a doctor, a medical doctor, Dr. Cole, in the shadows of the University of South Carolina as he studied a monitor that was hooked up to Beaufort Jasper Comprehensive Healthcare Center 136 miles away. And looking in that monitor, he showed me how he could detect that the patient 136 miles away was diabetic. I became a disciple of these community health centers since the 60s. And I've watched them develop into the kind of relationship they now have with the Medical University of South Carolina, where I was last week. Now, when I came here to the Congress, I hooked up with a Dr. Roy Rowland, who was a medical doctor here serving in Congress. And we tried very hard to get community health centers to be focused on back in 1993, 94, during the Clinton years. Now, a lot of my colleagues wondered maybe why I was so passionate about including a tremendous plus up to $11 billion. I want you all to know that when the bill left the House, it was over $20 billion.
I know.
It was over $20 billion for community health centers because these members here have had long experiences and are committed to this. Now, of course, somewhere between this side of the house or the Capitol and the other side,
The dark side.
we lost half. We lost half of our money. But I came here today because I wanted to hear for some of what I've heard today. But I want all of you to know that the record that you all are making today is a record that I am convinced will form the foundation for us getting this country to 100% coverage, which is what it'll take for us to have real prevention in health care. It's got to be out in the communities. It's got to be where people live their everyday lives.
Amen.
Or we'll never going to effectively deliver the wellness programs that we need in order to bring the real cost of health care down. So I want to thank you all so much for allowing me to be here. I think that Mr. Laura made a statement when she saw all these pages over here that my staff had prepared for me, but I'm not going to read it, and I'll yield back.
Always and ever eloquent, Mr. Clyburn, and again, thank you for your insistence on community funding for community health centers. Again, going to try to recognize people in the order that they came in, and with that, another doctor in the House, and which is Dr. Donna Christensen here.
Thank you. Is it on? Yeah. Okay. Good afternoon. And as a former director of a federally qualified community health center in my district, I want to thank the co-chairs and the caucus leadership for holding this hearing, and thank the panel for coming to help us tell the great story of community health centers. And from all that you've said, it's clear that the cuts such as the $1.3 billion proposed by the Republican majority in H.R. 1 would not only deny health care to thousands of some of our sickest patients, but it would also prevent the jobs we intend to create through the Affordable Care Act, and would further stop efforts of community health centers to stimulate the economies, as you so clearly pointed out, in some of the poorest areas of our country. So it's clear that the community health centers are a great investment because they not only treat illness, but they also address the social and economic determinants of our health. I want to focus my question on the importance of the health centers in eliminating disparities. The latest national disparity report came out, says that we're really not doing too well on eliminating disparities. And would someone want to respond to how the role of the health centers in eliminating health disparities, and perhaps also to the savings? I don't think anyone spoke to the savings. A lot of these cuts are being proposed because we need to reduce costs, save money, and pay down the deficit. But community health centers do produce a lot of savings, don't they?
Well, maybe I could speak a little bit to the health disparities issue, and Dr. Whalen, you might want to join in on some of the savings. But
Thank you.
You know, of our patients, a little over 50% identify themselves as member of a racial or ethnic minority. About 40% prefer to speak in a language other than English. So it's a very big tent that we care for at the Community Health Center. And I think we have learned, it's been confirmed by the Commonwealth Fund and others, that a high-performance health system raises all boats, right? That when you consistently apply the best care and you make sure that people can get the best care with electronic health records, prompts for reminders, fail-safe systems to go back and find those people who you've lost to care, that health disparities can be eliminated. Now, we can't undo, in the course of primary care, a lifetime of deprivation, poor nutrition, lack of access to equal health care. But wherever people are when we find them, and we don't wait for them to come to us, as you can imagine, we're very aggressive about going out, doing door-to-door neighborhood, knock-on-the-door campaigning, just like politicians do, to engage people in primary care. No matter where they are on that continuum from wellness to illness, when we find them, we begin to apply the principles of that high-performance system prevention in everything we do, even while managing and treating chronic disease and illness. We say today at the health center, we can look at our electronic health record and say this with some certainty. The good news is we have very little disparity between our groups of patients and outcomes. The good news, we're doing as well as the Geisinger and the other places that people talk about. The bad news is even the best places aren't doing well enough. It's great that 60% of our hypertensive patients are under control. That's a terrible outcome. That's the best we're getting in the United States. So we have lots of work to do, and I think that's the work that you are investing in, making sure we treat people early.
One thing about the disparities, I think that as a nation, we're doing miserable. But where we have seen successes, in fact, has been mostly at community health centers. And I think it's for a couple of reasons. First of all, it's because by design, 51% of the board has to be patients. So they are informing the care, they're informing